Hello and good afternoon, everyone. Welcome to today's webinar, Clinical Adoption of AI Across Image Producing Specialties. I'm Timothy Klein, Assistant Professor of Radiology at Mayo Clinic, and together with my colleague and SIIM Machine Learning Education Subcommittee Co-Chair, Felipe Kitamura, Superintendent of Applied Innovation and AI at DASA, we are thrilled to be here with you today. This webinar is brought to you by the ML Education Subcommittee, and we're working on presenting a few more webinars as we get into 2023.
Tim and I have the pleasure of serving as moderators for this webinar. We are privileged to have with us today 4 fantastic subject matter experts from medical imaging AI community. Please welcome Dr. Camilo Brandão de Rezende, who is an honorary research fellow at the Moorfields Eye Hospital, London, and also senior ML specialist engineer at DEMDX, also London. Dr. Marilyn Bui, senior member, professor of pathology, scientific director, analytic microscopy core, and director of cytopathology fellowship at the Moffitt Cancer Center. Dr. Roxana Daneshu, who is a clinical scholar at the Stanford University School of Medicine. And last but not least, Dr. Curdy Magudia, who is assistant professor of radiology at the Duke University School of Medicine.
We'd also like to mention that SIIM members are eligible to receive 1 hour of IIP-CE towards ABI-CIP certification or recertification for this live webinar. To receive the credit, complete the post-webinar survey, which will come up at the close of the webinar.
And after the short presentations giving a high-level overview of the state of the art of AI in each of the speakers' respective fields, and the panel discussion, we will be engaging in a Q&A session. So be sure to ask your questions through the Q&A icon found at the bottom of your Zoom control panel. So without further ado, let's begin. Welcome, Dr. Magudia.
Thank you so much. I want to say thank you to SIIM, to Anna Zawacki, Dr. Kitamura, and Dr. Klein for the invitation to participate in this webinar. And I'd like to give a brief overview of the state of AI and radiology in 3 main domains. These are research education, clinical products, and the future. So starting with research and education, there are a few topics that I think are of particular interest. The first is work on opportunistic screening, where we harnessed AI to generate imaging biomarkers that would be too labor-intensive to provide manually. And examples include CT-based body composition analysis, and if we could advance, coronary calcium scoring. Excellent, thank you. Next, there are many in radiology who are thinking about how to optimize education in radiology to prepare our workforce for the integration of AI into radiology practice, which are really important as we look towards our future. If you advance as well, thank you. And then last but not least, there are several interesting papers digging into bias algorithms and what we can do to mitigate and prevent the potential harm from AI algorithms. Here's one example of an FDA-cleared AI medical product that is an aid for pulmonary nodule detection. This algorithm removes normal lung parenchyma and vasculature to help pulmonary nodules stand out. In fact, this algorithm is used clinically at Duke, where I am on faculty. In total, there are 201 medical products using AI applied to radiology and other imaging domains that have been approved by the FDA. You can go to the ACR or the American College of Radiology Data Science Institute page, where each of these products are listed and categorized in a useful manner. Let's move on to the future of AI in radiology. The #1 resource I would point to you to look at regarding the future of AI in radiology is the RSNA Imaging in AI Practice Demonstration Project, where the utility of AI is demonstrated throughout a radiologist's workflow. These include AI assisting in exam ordering, protocoling, resource utilization, AI orchestrators that connect the radiology systems to the algorithms themselves, worklist prioritization, and report integration of AI results, and so on. Our main conclusion from this project was that semantic and interoperability standards are essential to the future success of AI in radiology. The many groups involved in the applicable standards are shown here below. And with that, I would like to thank everyone and to pass it along to my co-panelists.
Thank you so much for your presentation, Dr. Magudia. Now I'm going to call Dr. Danishu, please.
Thank you again so much for having me, and to all our organizers. I'll be giving a brief overview of the state of AI in dermatology. And so AI in dermatology covers actually many different imaging modalities, light photography such as clinical and dermoscopic, whole body imaging, confocal microscopy, digital pathology, and these are just a few examples. This is not necessarily comprehensive of everything. Many times when people, sorry, go back one slide. Many times when people are talking about AI in dermatology, the most common use cases are around photo capture using light photography. And this is not standardized in our clinics. And so people will use different kinds of cameras, different kinds of smartphone technology to capture these images. Next slide. And so there are some challenges that we face. So AI in dermatology is not as mature of a field as it is in radiology. And certainly we are learning a lot from our radiology colleagues. And one of the challenges that we've identified is that in dermatology, even though this is the case across many medical specialties, a lot of the data that has been used to generate publications around algorithms are siloed. And so here, this is from a scoping review where we looked at papers in deep learning and AI in dermatology, and every purple box represents a research paper, every circle represents a data set, and all the data sets that are in red are ones that are not available for sharing or further analysis. And all the data sets in green are the ones that have been made publicly available. And I would just like to note that the data set labeled number 1 represents the SIIM IFIC data set, so the International Skin Imaging Collaboration. And so you can see that that's actually generated a lot of research and is one of the largest publicly available data sets. Next slide. And then some of the other issues that we face are around label noise. So for example, looking on the left, papers that were looking at cutaneous malignancies, such as being able to detect melanomas or basal cell carcinomas, 37% of them did not use biopsy proven results and used dermatology labeling for image labels. And the reason that's a problem is at least in dermatology, for example, for a melanoma, a dermatologist has to, on average, biopsy about 7 to 8 suspected melanomas in order to discover a true one. And so just using expert labeling can lead to label noise. And one of the other issues that we deal with in dermatology is representation across diverse skin tones. And so we found that only 10% of studies even reported out what skin tones were used in their training or testing data for the algorithm development. And for those that did report that small sliver, many of them did not represent brown and black skin. So there's this huge concern for bias in the data that has been so far used to develop AI algorithms. Next slide. So as of now, there is one FDA-approved dermatology AI algorithm, but it does not utilize light photography. And that has been the focus of much of the development in this space. And so I sort of inspired by what's been done in other fields such as radiology, the International Skin Imaging Collaboration Expert AI Working Group put together a checklist for the evaluation of image-based AI algorithms. And just to help provide guidance, as I mentioned, we are sort of a bit earlier in our development. And so giving guidance around data consideration, techniques to use during development, technical assessments, and considerations for applications. And with that, that is my very short overview of the state of AI in dermatology.
Thank you so much. Yeah, please go ahead.
Hi, I'm Dr. Marilyn Bowie. I'm here to talk about imaging AI for pathology. So when we talk about AI, we usually have this image, pathologist reading through microscope of those glass slides, and we may have a robot replace us. So this is a wrong concept. The new concept is augmented intelligence. Pathologist is in the center of this ecosystem. We incorporate the radiological information, pathology information, clinical information, genomic information to provide diagnostic, prognostic, and predictive information to help guide the clinical team manage patients. So the AI for us is supposed to be augmented intelligence. So that's the new concept. With that said, in summary, we have 5 types of AI algorithms in modern pathology with the goal to improve quality and the efficiency of pathology practice to optimize patient care. So as you can see, I'm only focusing on the clinically impactful type of AI. First, it is detection, find things, rare events, metastatic cancer in the lymph nodes. Second is classification, to classify tumor into different types, adenocarcinoma, squamous cell carcinoma, or giving a grade. If you have a prostate cancer, there are certain grades that has prognostic significance. So there's a lot of interoperability variation between different pathologists. Using classification or using AI have the great potential to have standardization and reproducibility, and then quantification. And as you know, that many predictive biomarkers are really important. Not only you have to say they're positive or negative, there is a clear cutoff, some at a cutoff of 1%, some at a 10%. So human manual reading is not very reproducible. So quantification using AI is just one thing that we have to do. And especially for pathology stains, instead of the H&E, we have immunohistochemistry, and we have multiplex testing, have 5, 6 multiple markers on the same slide. This is all beyond the manual interpretation by pathologists. So computational pathologists and AI will be very helpful. So for prognosis and the prediction, that's the higher level of AI. Hopefully, after we train the AI incorporating radiology, pathomic, genomic, and outcome data, we are able to have AI to be able to review the HE slides and predict the cancer or disease prognosis and prediction. This is going to be very powerful to just speed up our diagnostic processes. So on the right side, and I'm showing some of the studies that my group is involved. And then this particular one is an example of a friend that they're using this AI to help with the quantification of a biomarker. So next slide. So this one is showing the importance of quantification. So in this state, on the left is lung cancer, on the right is melanoma. There are many immunomarkers on these slides. So AI is helping this to make diagnosis and make quantification. So this directly helps with the clinical trial to select patient for effective therapy. Next slide. So this is the example that a pre-clinical trial in an animal study for sarcoma. We are collaborating with the radiologist. So the goal is to be able to see the radiology image, collaborate with the pathology and outcome data to predict what features are predicting the response to certain type of therapy. So this is the theory, and this is going to translate into patient care. Next one. So with AI, as you can see, the machine learning in pathology start in the 1980s. Now there's an explosion in literature. Next. And this is a recent PubMed search. You can see the number of articles is coming out. This indicates this is the prime time for AI to be deployed in pathology. Next slide. So this is the lay of the land in 2021. And thanks, Dr. Toby Cornish shared this slide with me. And you can see on this FDA side has a great summary of what are the AI FDA approved. There are a lot of them are radiology, and the cardiology also lead the way. However, pathology is really catching up. Right now, it's showing one, but I can anticipate, and there are a lot more coming up in this recent years. Next slide. So this is the first one that got FDA approval by Page AI. What you're looking at is a prostate cancer, and this targeted area is to use AI to help identify prostate cancer used as a companion diagnostics for pathologists. In our practice, for prostate cancer is a very common breast cancer, is very common cancer in men, and there's a high volume. It's very tedious work for the pathologist, and there is also a grading. So we need reproducibility. So this algorithm is really helping out. Almost like if you're a private practice pathologist, you have a digital fellow if you use this program to help you increase your reproducibility and accuracy. Next slide. And in the pathology community, we are communicating, collaborating with the FDA. So this is a Pathology AI initiative. It's showing how the regulatory body and the pathology community and the AI developers can all work together so we can understand what are the high-risk areas, we mitigate it, and open up this pipeline to have more AI algorithms get FDA approved and people have confidence using them so we can use that to improve patient care. Next slide. So the standardization, collaboration, and the synergy is among all communities. So now here, we're focusing on those three. I'm personally involved. That's the Digital Pathology Association, SIIM, and also College of American Pathologists. And the leaderships are working together to find ways to collaborate. And this presentation is also a prime example. For me, I'm a SIIM member, and because Digital Pathology Association and sent me here to collaborate with SIIM, and I'm involved and I learned a lot from everybody else. So thank you for the opportunity.
Thank you so much for your presentation. Now I'm going to call Dr. Brandão de Rezende.
Hello, good afternoon, everyone. Thank you very much for the invitation. It's a pleasure to be here. So next slide, please. Yes. So to give an overview of AI in ophthalmology, it's important to highlight some characteristics of the eye. So the eye is an extension of the central nervous system, and it allows in vivo direct observation of neurosensory tissue. This has been explored recently, and AI models for detecting Alzheimer's disease, for example, have been proposed from retinal photographies, detecting Alzheimer's from retinal photographies. The eye is also the only organ where one can directly visualize the microcirculation. And as we know, microvascular changes occur in several systemic diseases, sometimes preceding the clinical manifestations. So alterations in the eye are associated with hypertension, diabetes, coronary disease, systemic inflammatory disease, renal disease, and stroke, for example. Additionally, there are several imaging modalities in ophthalmology that can be used as data source. Those modalities include external eye and retinal photographies, optical coherence tomography, with a spatial resolution of less than 10 micrometers, what is 100 times higher than the spatial resolution of magnetic resonance, for example, among other modalities. So in ophthalmology, we have an abundance of image data source. Next slide, please. Regarding current clinical applications, we are far from using AI at large scale in ophthalmology. This is in part because available systems mainly focus on the diagnosis or screening of a few diseases. There are 2 FDA-approved autonomous AI systems for the diagnosis of diabetic retinopathy. One of them was the first in any field of medicine to get FDA authorization for an autonomous AI. There are also a few AI systems that are CE certified. One of them can simultaneously detect diabetic retinopathy, glaucoma, and age-related macular degeneration. In addition, I would like to comment about 2 promising areas to be explored in ophthalmology. The first is augmented reality. Given that ophthalmology relies a lot on microscopes, there is an opportunity for predicting outcomes and diagnosing during the examinations and surgeries, and this could be used in training as well. And the second promising area I would like to comment about is retinal imaging-based oculomics. As the retina is the only human tissue allowing direct non-invasive visualization of the microvascular circulation and the central nervous system, it affords a unique setting for the characterization of systemic and central nervous disease. So potentially, we can find retinal imaging-based biomarkers of several diseases, and this is what oculomics is about. So that's my overview of AI in ophthalmology. Thank you very much.
Fantastic. Thank you so much, Curdy, Roxana, Marilyn, and Camilo for your excellent overviews. So we're going to start by moving on to the panel discussion. We put together a number of questions prior to the webinar. So we'll talk through some of those, but again, I would certainly encourage the audience members to type in some questions into the Q&A box. Looks like we have a few questions that have come in so far, so feel free to ask questions there. So we'll start with where is AI in terms of deployment and clinical practice within each of your fields? Curdy, do you want to start?
Yeah, thank you so much. So we're kind of at the point where we're working on optimal implementation and integration of AI tools. So we're thinking about monitoring, ongoing monitoring, generalizability, and bias. And this is a very complicated and complex situation, as anyone who's delved into AI knows, which hopefully means that AI tools are going to be safer and more appropriately interpreted than they otherwise would be. So I think realizing how complicated the situation just means that we're hopefully going to be safer and not just blindly implementing these tools. And I think here would be a great place to talk about this tweet that I recently saw by Kurt Langlotz that summarized the state of AI and radiology, I thought really well, and I feel like should be brought up at this webinar. So initially, we thought that AI would replace radiology. We've kind of all seen that out there in the media. Few of us, I think, actually believe that. Then 2, we thought that, people were just using whatever training data that they could get and developing these algorithms with really catchy names. Then people started focusing on regulatory approval and actually being useful to radiologists, which is more difficult than it sounds, it's very, very hard. And then thinking about being generalizable. So these are big factors. And now we really need to focus on clinical need, infrastructure, and implementation. So those are kind of the phases that we've been in, and none of them are easy, and they all have their own challenges. Sorry, I know I went on and on, but I feel like that's really where we are in radiology.
Yeah, those are great points. Thank you so much. Let's see, next, Roxana.
Yeah, as I've mentioned in my introduction, dermatology is lagging a little bit behind, as we don't really have any FDA-approved light image-based devices right now. And in fact, the FDA had an expert advisory panel in July, even discussing about how to classify single lesion devices, whether they should be class 3 devices or class 2 devices, And so the conversations in dermatology are still much earlier. We don't really have anything that's deployed clinically. And of course, as I mentioned, our data is a little bit less standardized, which makes it harder to make sure that you have algorithms that are completely robust to the heterogeneous way that the data is captured. I think that there are a lot of conversations happening within dermatology, particularly around how we can build tools, as was mentioned earlier, that can augment our performance, and the ideal way of running trials that actually test whether or not this augmentation works or not. And I think for us, we are looking at some of the other specialties and what's been done, and trying to take in the unique considerations and challenges of our type of data in order to hopefully set guidance and rules around building tools that will be clinically useful.
That's great. Yeah, you can learn a lot from the mistakes in radiology for sure. Nice. Let's see, Marilyn.
So for pathology, as you know, that the digital pathology is the backbone for AI development. So the first step is to digitalize the slides. And for radiology, you get rid of all those big scanners and the films, right? But for us, we scan the slides. So that's an added step. So that's added investment in scanner and IT infrastructure, but we are doing well in that sense. I think we have a much greater pickup in scanning the slides. And as far as digital pathology adoption, and we have like 3 types of models. There are big academic institutions. Their goal is first for clinical adoption. Second is for innovation. So they invest a lot of money, and they're the first adopt digital pathology for them to get to AI. So they are much more prepared. And then there are other groups, they are more like commercial laboratories, know that they're more using that for operational purpose, and eventually, if there are FDA-approved AI, and they will adopt it, but their function is more improve operational efficiency. And we have other areas, for example, drug development and all that. They're also very much involved in getting digital pathology so they can get into AI for drug development. So all those has been set up for the past 10 years or so with the collaboration of DPA, with the FDA, the CAP FDA. And with those collaboration, we were able to downgrade some of the scanners from 3 to class 2. And then there's a serious FDA approval with that. So that paved the road for the AI approval. So now these organizations are all working together for implementation of AI. And we are discussing of implementation, it's organized. We're discussing of payment, getting the CPT code. So I can anticipate the prime time is here.
Nice. Yeah, thank you. Let's see, Camilo, how about you?
Yeah, so in ophthalmology, as I mentioned, most machine learning systems remain the research stage, and only a few went to clinical translation. And among those that went to clinical translation, they are predominantly related with diagnosing and staging very few diseases, such as diabetic retinopathy and glaucoma. Probably this lack of clinical translation is the result of several factors, including methodological issues and generalizability. But in my view, that is natural, given that AI, especially deep learning, is relatively new, and probably several of the current issues will be mitigated over the next few years.
Nice. There was actually a question from an attendee that I think kind of fits here. You all touched on it, but would anybody want to comment on what the main barriers that you've encountered to successful clinical implementation of AI in your respective areas? maybe I just open up to any panelists that wanted to comment there.
Yeah, I would comment for pathology. One is the convenience. You have to build the AI algorithm into the workflow, because we had a quantitative image analysis tool FDA approved for a little while, but they were standalone. So you do your clinical workflow, you have to log on another application to do your computational pathology, and then you manually copy that number into your workflow. That's not going to work. So right now, all the vendors are really included. So in your digital workflow, and there's just a plug and play with a certain AI algorithm, and then that data can be incorporated into your workflow, and then you continue to move on. So that's very important. But at the same time, it's an IT challenge because you have to integrate all those buttons into your workflow. I think that's one. And I will leave this to other panelists to discuss, and I can add more later.
Nice. Let's see, Curdy, any thoughts from the radiology side?
Yeah, definitely. I would say informatics, and I think this is why we're here at SIIM, I think is, you know, one of the most important pieces of this. Having all the infrastructure that you need for implementation is a real huge logistical challenge. And, you know, there's a lot of bureaucratic and institutional inertia that kind of prevents people from doing things as optimally as they would like, at least at some places that I've been. So I would say that's one part. Another part would be the generalizability and making sure that everything is being done safely. So, you know, even if these algorithms are FDA approved, really thinking hard about what populations they were trained in, how applicable that is to your local population, thinking about local validation and ongoing monitoring. So even if you do local validation, continuing to monitor over time to make sure there isn't drift or anything that would kind of make you be concerned about the model results that are coming after that.
So Tim, I also like to ask a question, maybe that will generate some discussion. We know radiology is leading in FDA approved algorithm. You have like over 241. But when I ask radiologists how widely are those adopted, the answer is not very much. Then we can ask why not? Maybe that's going to help us to identify the barrier.
That's a great question. Curdy, any thoughts there?
Yeah, so I showed that one example in my presentation, that video, and I think part of it is that when we think about AI, it's like the sky's the limit, right? So you can think about these applications that are really, you know, like Superman solving all of our problems. But the truth is that starting small is probably better, and I think that's why this kind of clear read CT program has been successful, because it is an aid to the radiologist, making the job a little bit easier. And I can see that, you know, the trainees at my institution and a lot of the attendings trust this AI algorithm and are using it. So I would say thinking about things in terms of baby steps, not in terms of, you know, massive leaps at a time, I would say is important. And I think is how we've made progress at places. And I think it's just slowly building trust and giving people some feedback as to how the algorithms are doing. And I think the black box aspect, I think, is another important piece. So anything that has a little bit more explainability to it and ability to provide feedback is more helpful, rather than it just being an answer or a value that's provided.
Mm-hmm.
I'd like to bring up a perspective in dermatology, which probably is not as much of an issue in other specialties, which is the direct to consumer application. And it's to say that as a specialty, we have concerns around that, because when we talk about deploying AI clinically, we know that when we have a clinician in the loop, we still have someone who is a human expert who can look at what the output is and presumably make a clinical call on their best judgment about whether or not something makes sense. Like we do with any kind of test or diagnostic tool that we have sort of in our back pocket that we use every day. We know when, you know, information and the clinical picture doesn't go together, and we know what the next steps are in order to make sure that we get the best outcome for patients. What has been happening in dermatology is, because the skin is an accessible area, is that particularly outside of the US, where there is not as strict regulatory protections, there are companies that are releasing direct to consumer applications purporting to be able to detect melanomas and skin cancers and provide reassurance. And so in our specialty, we find ourselves having conversations on two fronts. One front being, how do we build sort of the best practices for deploying tools that our clinicians can eventually use, but also how do we sort of push back against commercial development for direct to consumer products that may actually cause harm and do not have trials backing up their use.
That's an excellent point, Roxana. And I think your point shows how peculiar AI implementation may be depending on this specialty. And this direct to consumer is something very specific of dermatology. I wonder if there's something specific to ophthalmology, Camilo.
Yes, sure, thank you. So I've already talked about some unique characteristics of the eye, such as the direct visualization of the microvasculature and neurosensorial tissue, and also about the multiple imaging modalities that we have in ophthalmology, but that also results in several challenges. So for example, how to scale models relying on multiple imaging modalities. You may need multiple expensive devices, specialized personnel, and a complex system integration. And also, the devices are highly heterogeneous, and this makes more difficult to build and to evaluate models compatible with them all. So those are some of the relevant aspects of AI in ophthalmology that I believe should be highlighted.
Fantastic. One interesting thing about this webinar, I'm just thinking right now, because I've been delving into AI in radiology in the past years, and I guess Tim has done similarly, and Kirky. But I think this is very interesting to have this kind of conversation among different medical specialties and see how things differ and how we can learn from each other. And I think SIIM brings this kind of perspective, this unique perspective. We do have some other questions. Yeah, go ahead, Doctor.
Yeah, right. So I'm still waiting for the answer. What's the barriers in radiology that prevent all those 241 algorithms being widely adopted? But before that, I like to offer just some perspective on the challenges in AI development and implementation. So the first barrier is regulatory. People trust FDA approved products, and that's a process, right? So we talk about the DPAs, the CAP, and FDA are collaborating, communicating, so we can make that approval process more streamlined. So that's what we're doing, and we already have FDA approved the product, more are coming up. So that's a good news. We're breaking down that barrier. The second barrier is the interoperability. And now different vendors have different platforms, and what's your imaging standard? And then we're using DICOM because radiologists are using DICOM, but is DICOM the only answer? Is DICOM the perfect answer? Those are all up for debate. So, and also another challenge, the third challenge is, how do you train your AI algorithm? And we already heard the unconscious bias within the AI, and the skin color is one, right? And also when you train your data set, and are they scanner ergonomic? Are they staining ergonomic? For example, if you're doing H&E, the variation is smaller, but if you're doing immunostain, even it's the same antibody has different clones, different platforms, how are you going to train them? So there's a lot of a data set training type of challenge there. And also there are other challenges as for pathologists. Do they feel comfortable using it? How are they going to use it? So those are all some of the challenges in the AI implementation. But as I said, there is our community, pathology community is very organized. We have people really work on those topics. But the biggest challenge is those tools make us much better in helping our patients. Are we get paid for those? Is that going to be additional expense for us? As we said, we add the scanner, we add AI, those are all business expenses, but the government don't pay you for efficiency, right? They pay you by the amount of work you do. So the current payment model is not really encouraging investment in diagnostic medicine. So we have to work with the government to advocate for reimbursement so we can get paid to help our patients.
That's a great point. I totally agree with everything you mentioned. And in your last topic, I guess it's related to the return over the investment as well, right? My impression is that we might see the same scenario across all medical specialties, but I wonder if any of the other panelists have a different view on the return over the investment on these AI tools for your specific specialty, or if what Marilyn described is what also happens to your specialty. Maybe,
so, yeah, if you have FDA approved the product, you use it. Do you have a reimbursement code so you can get paid, or you just do it and you build it as your business expense? That's not sustainable, right? So that's the question.
Yes, so I believe that's a major problem, the return and the payment and everything, but also some approved AI tools ignore several aspects related to clinical adoption, not only the payment. So for example, as I said before, you have an autonomous model to detect diabetic retinopathy. Okay, so what would happen if we use this model in a patient with a choroidal melanoma? We will just miss the case and tell the patient that there is no diabetic retinopathy. That's not acceptable. So the applications of such models are really limited. And also, machine learning is dynamic and it requires continuous cycles of data collection and model adjustment. And for example, you can have now an excellent model to detect COVID, but in 2 months, you have a completely different variant and the manifestations are different. So your model is not good anymore. Another point is that most models remain focused on detecting abnormalities that, when detected, require more examinations and referrals. And if we generate too many false positives, we may increase the demand for healthcare resources without a real health benefit, aggravating the health workforce shortfall. And the cost of healthcare may increase as well. So I believe this part of the cost is related with also how to pay the doctors who is receiving, but also I believe we have a lack of health economics analysis of AI in healthcare.
Yeah, I saw there's a question asked, do you use combined AI models? For us, we don't have a lot right now, so we haven't really get to that part. But I would not be surprised if people are actually doing it. For example, you have 2 prostate companion diagnostic model, you have access to it, you may want to do it. This almost look like weatherman, right? When you predict if the hurricane is coming, you use different models, and then you decide which one is more reliable than that. So I would not be surprised if people have access to it and they may use multiple models. But at the end, we have to understand those are tools, and the people signing out the pathology reports are pathologists, and we will make the decision if the information is helpful or not. This just reminds me that when we make calls on the prognostic predictive markers, and we will say this is positive or not, we'll decide a patient will be put on a very expensive drug or not. And that drug will be effective only to the patient that are positive. If they're negative, it's not going to work and may cause some damage. However, right now, without the AI tools, many of us just do it manual reading. So that's not as reproducible. And especially if the number is low, the stain is pale, if you have to interpret it at lower level, the reproducibility is just miserable. So there's a great need for using the AI tools. So like when you go to the restaurant, you calculate the tip and you pull out the calculator. Then you decide how much you want to pay for the waitress. However, when we are doing the predictive biomarker interpretation, we don't even have a calculator. We're doing the manual reading. That's kind of scary. So there's really a great need to have the calculator, have the diagnostic companion to help pathologists to do a better job.
From the radiology literature, there are examples of ensemble models that are using multiple models. This is on the research side. I'm not aware of it in terms of products that have undergone regulatory approval, but there have been shown in the research setting to be benefits to using ensemble models versus individual algorithms.
What I'm hearing here is almost human ensembling. And I wonder if down the line there are going to be commercial products that build upon ensembling multiple other commercial products.
Yeah, yeah, and also there are multiple questions from one participant, Jim Watson. So which one do you want us to answer? So that's in the Q&A. There are multiple Q&As there.
I thought one that could maybe touch on was, so yeah, Jim asked about, I think the quality of the data that the AI is trained on. So I'll just read the question as it's written, but once we start to digitize images, we touch on the issues of transmission and storage. A lot of systems use varying levels of compression or encoding. Do the best AI tools require the best raw data? Or does the panel see a time when, for example, compressed images would be sufficient for training tools? So thoughts on, data quality, et cetera. Maybe, I don't know, Curdy, do you want to start?
Yeah, I would love to start. So this one, I actually thought this was such an interesting question as I saw it in the Q&A. The radiology data sets, and I think data sets, especially in pathology and elsewhere, can be massive and huge. And I deal with this all the time. I actually run out of space for these research projects. And in radiology, we're thinking about how much storage space we have for our clinical systems as well, which is very expensive. So I'm working with prostate MRI, and each of those data sets is on the order of a gigabyte or so. So when we're talking about research projects, we're in the terabytes range. And what we found with one of our models was that actually downsampling or doing some compression of these images was actually helpful for model performance, which was interesting. So I think that sometimes thinking about how much, depending on the type of computational resources you have, being able to get enough of the entire exam or image in there at the same time is important. You don't want to just patchwork everything if possible. So I think there are cases where using more downsampled or compressed images is actually helpful and not hurtful to the end result.
Mm-hmm.
In dermatology, we have this issue where, again, I've mentioned that light photography is an area. And so these smartphones, iPhones, Android, run, they compress images in different ways. They also, camera phone photography is built around making you look better, right? And so they may do some smoothing and other functions that are not ideal. Not only that, like many of our images, once they're loaded into Epic, I spent some time trying to understand what happens to an image when it goes in Epic, because when we're pulling images down to try to train algorithms, we are pulling them from Epic. And I couldn't really get a good answer from our research IT team in terms of what was happening with those images. So for us, to build something robust, it means that you're going to have to be robust to these kinds of perturbations that happen. And so that just adds in a layer of complexity. And I think this is why this question is very specific to each specialty and what kind of imaging modalities they're dealing with.
Yeah, for pathology, our data has much larger size than other specialties. And also this question is specific to a technical component that the data scientist is more familiar with. From what my understanding, people do different things. They can either choose areas of interest. So you have those little areas, and then you stitch them into the areas of interest. Or you can have the whole slide images. At a certain point, you have to compress it, but there are a lot of technical components. There are literatures published in that, shows the pros and cons. I don't think I'm expert in that, but I understand that that's almost like a very important technical component. How do you compress the data and then train your data on it? So that's pretty much my understanding of it.
There's a whole webinar for that. Oh, go ahead, Felipe.
Yeah, no, go ahead.
No, I was just, I was going to see if Camilo had anything to add, and then I think we probably have time for one more panel question, but wanted to give Camilo a chance.
The only thing I'd like to add is that we need to differentiate between the inputs and outputs of our AI models. So the images are the inputs, and as was mentioned, if we have more variety and if we have data of less quality in the inputs, our models might be more robust and more generalizable. But one thing that is essential is the quality of the data of the outputs, so our labels. We can't have wrong diagnosis in our data set. And actually, we use that when we are doing the models as data augmentation. We get the images and we just put random noise and shift the images and do lots of changes in the original image to make the model robust to change. And if you only use models, if you build a model only using images with high resolution from a specific machine that's really good, you won't be able to generalize that model for other machines that are not that good.
Yeah, that's a good point. Yeah, it usually helps regularize the models to do data augmentation. That's a good point. So we have a question from our colleague radiologist from Argentina, Marcelo Sarachaga. He's asking a question that we have heard a lot in radiology before, and I wonder what the answer is for other specialties. I know that you are all experts in the field, so I understand you may have a different answer to that, but I wanted to know what's your impression of what your colleagues in your subspecialty think about being replaced by AI. Is there a fear in that?
Who do you like to go first?
Could be you.
The fear is there, but it needs education. So that's why I start the conversation with that image. The AI will help us a lot. The purpose is to have AI tools to augment our ability, because there's studies showing for metastatic breast cancer, even you use the best specialized breast pathologist, the error rates will be, say, 7%. And then if you use good AI, the error rates will be 5%. But when you combine them, it will be reduced to 0.5%. So we need help from AI because our pathologist workforce is shrinking due to the aging, less people coming in, due to our work, it become more expanded in the area of precision medicine. So we do need help. AI will provide that help. However, there's another question talking about for the older people who believe seeing is believing and believe we are better than AI. On the other hand, all the AI in gaming and like playing chess and already show AI has its own ways of learning, and there are times can surpass human capability. So the interaction between human and AI at one point, the AI may be smarter than us, and how do we feel comfortable then? So at a certain point, we may have to trust what the AI can do. But as far as will AI will ever replace us as physicians, the answer is no, because AI will always be a tool. And with that, I have the ultimate confidence that we will be augmented pathologists, not be replaced by AI.
Very good point. Will ophthalmologists be replaced, Camilo?
No, I believe the answer is the same that I was given.
Mm-hmm.
AI is here to help us, not to replace.
What about Derm, Roxana?
I think to your question of what does the specialty think specifically, I think it's a mixed bag. I think the American Academy of Dermatology has done a great job about having this discussions around augmented intelligence, which was mentioned. I think that if there is concern, a lot of it has been driven by sort of hypey, article, news article titles, which is really where a lot of this is coming on. You see these, article titles being like, AI is better than dermatologists, AI will replace dermatologists, but it's not truly looking into the nitty gritty about robustness, fairness, the lack of good clinical trials assessing. We just had one of our first clinical trials that was published, and it showed that the algorithm improved the performance of primary care doctors in skin lesion diagnosis, but actually not for dermatologists. And on retrospective data, that algorithm had beaten dermatologists on, large scale retrospective studies, which aren't really representative of what's happening in clinic. So I think in our specialty, that conversation's still ongoing, and the concerns are really are driven by things people have seen in the media, which are not accurate representations. And I think that's where people who live in both worlds provide a unique perspective.
Awesome, thanks. What about radiology, Curti?
Yeah, I agree. I agree with what everyone else has said. I mean, I think there was initially a lot of fear. I think that the societies and generally, I think a lot of that fear has been allayed. I think people are hoping for that augmentation and that aid that can come from AI. So I think there's a lot of people waiting for that help and seeing how it can be implemented well and integrated into practice, regardless of whether you're at an academic center or in private practice. And I think that by itself is still challenging.
Fantastic.
All right. Well, unfortunately, I think we need to wrap up now. I think we could probably chat for another hour for sure. But thank you so much for this discussion. We're also going to put together a blog post based on the webinar and potentially have some more answers to a lot of the questions that we weren't able to cover in the time here. So I'm just going to close us out. So, thank you again for joining us today. The webinar will be archived shortly and made available on SIIM to members. Please stay on for a moment after the webinar is ended to take a brief survey to help us plan future webinars. And again, SIIM members are eligible to receive SIIM IIP credits towards OBI certification and recertification. And to receive the credit, complete the post-webinar survey, which will come up at the close of the webinar. So Felipe?
Yes, I just wanted to thank you all, Curti, Roxana, Marilyn, Camilo, and Tim. It was great spending the last hour with you all. We look forward to seeing everyone again soon. Have a great rest of the day.
Thank you. And nice meeting you guys virtually. Bye-bye.
Thank you.
Thank you. Bye.